Thank you very much for joining us for today's webinar. During Women's Health Week, we have a series of programs, and this is the first one. When we initially advertised this program, I think we gave it a topic that was something around research, MS research and care for women. Annike's been able to define that topic further for us, which is great. And today we'll be looking at women and MS, and we'll be looking at health throughout the lifespan. I'm Andrea Salmon, one of the Education Program Coordinators at MS, and I'm facilitating today's webinar, and Associate Professor Anneke van der Walt is our guest speaker today. We start all our programs by acknowledging and paying respect to the traditional custodians, past, present and emerging, on whose lands we meet today, and that applies no matter where we're dialing in from. We acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and we respect the cultural authority of the elders in each community. It's my pleasure to introduce you to Associate Professor Anneke van der Walt today. Anneke is a neurologist at the Alfred Health Hospital in Melbourne, where she's appointed as the head of MS and Neuro-ophthalmology. She leads the Multiple Sclerosis and Neuro-ophthalmology Research Group at the Central Clinical School, Monash University. Anneke completed her undergraduate training in South Africa before relocating to Australia, where she completed specialist training in neurology and a PhD in neuroscience at the University of Melbourne. She has a vast range of interests in the research that she undertakes that includes treatment of MS tremor, better monitoring of cerebellar dysfunction in MS, and MS cognition. And she has a keen interest in women's health, as well as symptom management. And it's that keen interest in women's health that led to us asking if she would be willing to share some of her knowledge with us today as part of the Women's Health Week programs. So Anneke, it's wonderful to have you online. I'm going to click a couple of buttons here so that you can show your screen.
All right, so I'm going to talk to you today about just sort of thoughts about different aspects of a woman's life and how MS could affect that, really. So I guess, you know, as we all know, MS affects women much more than men. And we know that, you know, this is actually on the rise. So most MS patients or people with MS are between the ages of 30 and 34 years old. And this incidence of women to men is actually slowly increasing. So it's not quite clear why that's happening, and it does appear to be mostly true in the Northern Hemisphere. So you can see how this has been rising over the decades. And it seems to be closely related to where you're actually born. But between 1981 and 2011, the MS has slowly increased, but the range of female to men has also almost tripled from 1 to 1 to 1 to 1 to 2 to almost 1 in 3 people now being 2 out of 3 being women. So I guess the first time that hormonal effects and being a woman starts to impact on MS is really at puberty. So at the menarche, which is really the onset of menstruation. So we know that the elevated risk of women developing MS really started in girls when they start puberty. And puberty is actually gradually shifting to earlier and earlier in industrialized nations. For a number of, you know, speculated reasons, but none that are that clear. We also know that starting puberty early could be a risk factor to develop MS or MS symptoms. And it could be that, you know, a certain predisposition from genes could play a role here and make MS start earlier. But we also know that, you know, being overweight, in particular when you're an adolescent, could actually also come into play and increase someone's risk for MS. These hormonal changes that happens in young girls have a potential downstream effect in the immune pathway. So what that means is that, you know, all of these hormonal changes could actually lead to changes in the immune system that can lead to someone being programmed to be more inflammatory in nature. And these higher relapse rates, we know this because the relapse rates in the early years after MS starts, particularly in childhood MS, it's much higher just after the period starts. And this can, of course, have a huge impact on a young girl who's not only just started with having to deal with regular menstruation, but also, you know, usually at a very sensitive stage developmentally, academically, and just in terms of developing your own identity. So you can imagine that this would have potentially a huge impact on a young girl developing a disease like MS so early on. When we think about adult women, there's of course a number of things that have to be considered. So we think about not only you know, things like pregnancy, but also, you know, sexual function, work, relationships, and the whole complexity really of being a human and living in a human life. So I guess, you know, with MS, you could, you know, we all start off, you know, you start off single, and, you know, you can be a fabulous single lady, and then you could get MS along the journey. And sometimes, you know, you stay single and fabulous, and that's great. And sometimes, you know, you get older and you have, you know, lots of life experiences, and, you know, people often rely on lots of people throughout their lives to support them along their journey. But then for a lot of people, when they develop MS, they're often in a situation where they're juggling a lot of different roles. So, you know, usually, you know, work, it could be relationships, it could be, you know, children or grandchildren, or finances, and multiple things really, which makes any person's life complex, and even more so when you also get given a hand that has MS in it. So to illustrate some of this, I'm going to talk about a case, which is a young woman who was 26 when I first started seeing her, who had optic neuritis, so visual involvement in 2008, which did fully recover after about 6 months. And then quite shortly after, about 6 months after, she developed weakness a little bit and some balance problems. But she did reasonably okay. She was very active socially, and she'd actually at that point just met someone that she'd liked, and she'd been dating this person for a while. But she was really worried about, should she disclose that she has MS? You know, so should she tell? And she was very worried about this, as you can imagine. So I guess the first thing to say, you know, what about mood in MS? And we know that women and men's cognitive experiences of MS can be quite different. And this, it tends to be, you know, this is not universal, of course, at all. But there are some evidence to suggest that women are less likely to experience depression or apathy than men, and are a little bit more likely to become a bit anxious. But at the same time, we know that that women, you know, are often better. They often have the ability to cope better and to maintain a perception of a much higher quality of life than their male counterparts. And that can happen even at greater levels of anxiety or ambulatory problems. So it certainly is something that, you know, seems to be quite described in women. It looks like my lines have shifted either. And when I thought about dating in MS and this patient's question, I came across this blog that was written on the Mighty, and I don't know if any of our listeners are familiar with this blog, but the Mighty is really, you know, a very good sort of chronic disease platform where you touch base with people with all sorts of chronic diseases. And this particular person, Deanne Moyes, she wrote about her dating experience when she was dating, and she thought about the fact that, you know, when she was 17, all she had to wear was something nice, you know, and a nice t-shirt, and the guy that she was dating, and that could be a guy or a girl really, nobody cared really, you know, whether anything was different. It was just about being cute and cool, and there wasn't much more to life to that. And, you know, the guy that you were dating wasn't, you know, that interested in anything else either. But now that she was 27, things were different because she was older, and she actually had a lot of baggage already because she, you know, had other relationships, and she had all of this baggage that she said one of those bags were being stamped with 2 huge letters called MS. So she talks about a guy that she went dating, and, you know, she sort of talks about this in a joking way, that every dating website she's ever been on, You know, everybody has to like the outdoors and like hiking and bushwalking and things like that. And this guy wanted her to go on a first date in August in the US, in the middle of the desert, in the heat. And she just wanted to laugh out loud. You know, and she's like, well, should I tell him why I couldn't hike in the heat like that? Maybe, but she tended to wait a little bit longer. You know, and then she sort of talks about different people that she dated. She called him, there's a guy that she dated called Mr. Spectacles. And she loved him so much. She was completely besotted with this guy. And, you know, she really stressed so much about telling him, and she couldn't even look him in the face when she finally got the courage together to tell him that she had MS. And you know what? He just shrugged and said, okay, whatever. So, you know, it's interesting, our perceptions and our fears might actually be, you know, not as bad as we think it would be once you get it out there. So then she dated lots of different guys, but it turns out Mr. Spectacles was a bit of a cheater. So Dan, the fisherman, so this guy, you know, he really liked to hang out on his boat all day. So you can imagine in the middle of summer, hanging out in a boat, exposed to the elements, you know, like that sort of heat made her feel so crappy that she would just not like it at all. Then she dated a guy, computer guy, Mike, but he didn't like all the other bags that she had, which included some kids that she had from a previous relationship. And she realized, well, if he can't deal with even, you know, things like that, there's no way he's going to handle her MS very well. And then she dated someone called Tall Robbie, and she liked him so much, and he also liked hiking. And she likes hiking, but not every day, and not when it was boiling and scorchingly hot, and not for hours and hours at a time. And she, again, you know, thought about telling him or not telling him, and what should she do. And she did in the end. But, you know, I guess, what would you say if you had to say, when is it a good time if you're dating to think about this? And I think, you know, I haven't, you know, had to date for ages, which is, you know, kind of good, I think, because it seems quite scary to me. And having MS would add just another whole dimension to this. It's really important to look after yourself first, and to think about the fact that, you know, even if you're super excited going on a hike in the middle of summer on a 40-degree day, if you're heat sensitive, is maybe not the best idea. How is your energy going to be affected by having a massive meal and having a few drinks? And making sure you have your support system in place. You know, who are you going to debrief to if things don't go well, or they go very well and you need to talk through it? I think telling someone you have MS is different for everybody, and you should do it when you feel ready. And some people are happy to come right out with it straight away. They don't see any point to wait. But sometimes, you know, some people would like to wait first to see, well, is this actually going somewhere before sharing something so private about yourself. I think it's much easier to tell someone you have MS if you actually can verbalize exactly what it is. So knowing what it is properly, even though you might, you know, have it in your head clear, saying it out loud and explaining it to someone else actually takes a bit of practice, and to explain it quite clearly. And sometimes it's good to have a practice run, you know, like saying this in your head to the mirror or something, or saying it out loud to someone else. And you could also be a bit non-specific, you know. You could say, you know, I have, you know, these and these symptoms, and you could say, I feel tired sometimes. You don't have to go into massive amount of specifics. And you might just say, well, I need to keep our plans flexible because sometimes I get tired quickly, or maybe, you know, I'd like to do this rather than this, and being much more clear about your own needs. I think in the end, you know, rejection is very scary to all of us. So I think it's important to remember that any person is more than MS. And you have the love to give and the right to be loved. And if some people have a problem with it, they might run away, but, you know, they are often the exception. You know, I think people would sometimes surprise us, and people who do run away should probably avoid it anyway. So although the dating world is quite scary, you know, just because you've got MS, it's more complicated, yes, but terrifying it is not, I admit. And you're a work in progress. But, you know, in the end, it's best to own it more and more, and hopefully you'll find the right person down the line who's going to be your wingman or your wingwoman through this journey that you call MS. So thinking about dating, we have to think about contraception. And I think, you know, luckily with MS, there's no specific interactions between disease-modifying treatments and contraception. With teriflunomide or Aubagio, there might be some evidence that you could think about that there is, you know, if you have a lot of teriflunomide, it might increase some of these hormone levels that you see in pills, in the oral contraceptive pills, but it's actually not really severe enough to affect how these drugs work. Sometimes, and I'm not sure if anybody would be familiar with this, but if you wanted to wash Aubagio out of your system, you would really have to, you can take this thing called cholestyramine or activated charcoal that will mop it out of your bloodstream. And in those cases, it's good to use some extra contraception if you need to. So our patient, our person that we're seeing, this ABC, she comes back to me a few months later, and very surprisingly feels very well. Well, not surprisingly she feels well, but she actually was in love, engaged, wedding date set, all done. And, you know, I was pretty keen to talk about what treatments she should be on, but she wanted to talk about starting a family pretty much straight away. So that really, you know, was where we started our conversation, and this is very early after she was diagnosed with MS. So the question she was asking was really, you know, will pregnancy affect her MS? Will she get some attacks? Will the pregnancy actually make her MS worse? Or could she actually get more disability over time? Will MS affect the pregnancy outcomes or the baby? And what about the medications? You know, we should talk about that. And will she be able to breastfeed? So I guess if we think about that first question, it's about pregnancy and does it affect MS? There's a very well-known paper that was published in 1998, which really looked at relapses in women with MS and how that changes during pregnancy. So what we can see here is relapses, but before someone got pregnant. This is during pregnancy, this vertical block, this rectangular block here. And then after delivery, we can see that the relapse rate actually, you know, drops down in pregnancy. This goes down and it's lowest in the third trimester of pregnancy. But then after pregnancy, so in the first few months of pregnancy, that relapse rate can rebound and shoot up and it takes a while to come back to where it was before someone got pregnant. So you can see that risk increases for about 30% almost. Of having a flurry of activity after the baby is born. So is there a way to know what your specific risk would be? Because we know everybody is different. You know, so I guess the first thing to say is, well, it very much seems to depend, and this is sort of a big study that's been done in the MS base registry and a number of other places, and it looks like how stable your disease is when you go into a pregnancy is a very, very strong predictor of how you're going to do in that postpartum period. So how many relapses you have in that first 2 years, in the year or two before you get pregnant. It also looks like in people who was on disease-modifying treatment for MS, they seem to have less chances of having this burst of activity after pregnancy. And if you have, you know, some neurological problems already before you get pregnant, that might flare up a little bit. And we also know that with some of the medications that we use, particularly the very highly active drugs, so the very drugs that have a very strong effect on your immune system, if you wash them out for too long, so if you stop them for a long time before pregnancy, then the disease activity could actually come back a bit earlier than after pregnancy. And it could be possible also that breastfeeding, especially if you can do it around the clock for 6 months exclusively, that might actually dampen some of this relapse activity this after the baby's born. What about miscarriages or terminations? Because, you know, you don't always know what is going to happen in life. And sometimes, you know, these things happen, like miscarriages are quite common, and sometimes pregnancies are just not the right time for the person getting pregnant. So we know that, you know, in this big database of pregnancies, that the risks of relapses after you have a miscarriage or an elective termination is actually quite similar as if you've had a real pregnancy event, a full pregnancy. So it looks like the effect that it has on MS and MS relapse activity can actually be quite similar to as if you've had a full pregnancy. So I guess the take-home message would be that overall we think that pregnancy has a very favorable effect on relapse rates. and that it declines towards the third trimester. We know that the relapse rate will peak and almost double to double the pre-pregnancy relapse rate in the first 3 months after pregnancy. And it can take about 2 years almost for that to stabilize back to what it used to be before you got pregnant. And then it's also really important to think how someone is functioning before they get pregnant. And it's best to go into a pregnancy as stable as you can be, and try and plan it if you can. And miscarriages and terminations would have the same effect. It's possible to avoid that relapse rebound if you, especially if you go into the pregnancy quite stable, if you've been on disease-modifying treatment, and if you haven't had too much of a washout, and actually also starting back on your disease-modifying treatment after pregnancy. So why is this? Why does this happen? It looks like there is specific immune system changes that happens during pregnancy, and which is very much driven by evolution. So your immune system adapts so that it doesn't reject the fetus or sees the baby as a foreign thing. So your immune system generally dampens down, and it's really one of these amazing evolutionary designs that women have. So what about pregnancy? Can it actually protect you against MS? And this is quite interesting because in this longitudinal study, we showed that this data that was collected over a long time in Australia, they looked at women who's had a first ever demyelinating event, and they looked at people without MS, and they then had a look at how many pregnancies people have had. And it looked like the more pregnancies you had, the less likely you were to actually ever have an attack of MS. Or it definitely it could delay when that first attack actually happened. And this risk reduction they did not observe in men. So obviously, we can't keep women pregnant all the time, but pregnancy itself has actually got a very powerful sort of a modulator on MS disease activity and when that first attack could happen. Another question that our Miss ABC had was whether pregnancy could make her MS worse. So could it actually speed up the transition to a more progressive disease? And many different studies have looked at this, and they have found maybe subtle differences in terms of how long does it take someone with MS who's been pregnant or not pregnant to need a walking stick after that pregnancy. And lots of different definitions have been applied. But overall, it doesn't look like this actually has any impact on your long term, how you're going to end up, 20 or 30 years down the track, whether you have a pregnancy or not, in a bad way anyway. So I guess in the long term, overall, we don't think that there's any impact in the long term on your MS outcome if you get pregnant, and it could actually be quite beneficial. And again, the relapse activity before and after the pregnancy is sort of one of the main predictors that tells us how someone's going to do. So can MS actually affect your pregnancy outcome and what happens to your baby? And we know that probably that babies born from MS mothers are often a little bit smaller than by weight than mums without MS. But there's really no difference in the developmental scores of these babies, so they all get born with really healthy scores just after birth. There could also be, in terms of delivery methods, a slightly increased risk of an operative delivery, which means that there could be a slight increased risk of having, say, a forceps or a vacuum delivery or requiring a cesarean section. But it's very difficult when you look at these studies to know if that's really because of MS or is that also just because of healthcare workers and everybody around this woman who is pregnant being a bit more nervous as well. But we know that fatigue can actually be, play quite a role in a woman with MS giving birth. So it's one of those questions that's not quite clear. But there's certainly no increase in birth defects generally, or babies dying early on, or any other adverse effects on babies, which is really great. The next thing to think about, though, is how MS treatments can actually affect pregnancy, and it's really important to understand the drug and the duration of the drug, how long is it in your system before it's eliminated, and also the duration of the biological effect of the drug as well, because sometimes a drug can be eliminated from your body quite quickly, but the actual effect that it can have on the immune cells and on the brain will actually last much longer. And also just briefly, I'm just touching on how these medications are classified and what it all means. I think it's important to just understand how these classifications and how this information all gets put together. And I think firstly, we have to remember that this is often labeled and put together at the time when a drug is first marketed. And the safety data was usually be collected over a few years. And usually, you know, these clinical trials, and anyone who's ever participated in one would know, when there's a drug involved, it's often selected to a very specific group of people. And they would really try and, you know, get you not to get pregnant, but people do get pregnant sometimes. Usually there's very limited information about what will actually happen to someone getting pregnant on one of these medications, and what would happen to that baby. But they have to make a classification using that existing data, and a lot of it's often based on animal studies, where they look at the biological properties of the drug, or they give really high doses of the medication. So, and we know also that, you know, what the risk is to the actual baby really depends on what the drug is, but how long the baby was exposed to the drug. And we also have to remember that any pregnancy has about a 1 to 2% risk of the baby being born with some sort of malformation, however mild that could be. So you have to always compare what you know about that. So I guess I didn't want to spend too long on this, because we have spoken about this in a previous webinar, but it means that we just have to plan it a bit, you know. So we need to think about what is the discontinuation period before conception, and this is usually recommended by a pharmaceutical company, and based on that sort of initial data, like I said. So, so you can sort of see that it varies from just a couple of days, where these drugs could actually be eliminated from your medication, your body, like something like Tecfidera or dimethyl fumarate. That's actually, most of it, 50% of it's out of your body within an hour, you know, so it actually gets out of your body quite quickly. But then these drugs actually have a long effect on the cells that they work on. And for something like, for instance, ocrelizumab, or even, you know, alemtuzumab, cladribine, these drugs, the way that they work lasts for a long time. And we often think about these effects as well when we try and develop guidelines to say, well, this is how long you have to wash a medication out of your system. So we need to think about, you know, other things. We have to remember that getting pregnant is different for everyone, and it takes longer. And like, it can take, for some people it's very quick, for some people it's really long. When it's possible at all, it's better not to be on any medications when you get pregnant. However, we know that there is a risk that, you know, if you stop medications too early, or you could actually cause more harm to the actual mother by causing relapse activity, or activity after the baby is born. So it's important to have, you know, a good plan for this. And, you know, for some women where we know that they've had high disease activity or lots of relapses, it might be better to continue the therapy until the pregnancy is actually confirmed, or sometimes even throughout pregnancy, which we're actually starting to do more often these days. What is interesting is that, and I'm showing here some data from a study that we published not too long ago, where we actually looked at pregnancies between, you know, 2005 and 2010, and then pregnancies in women between 2011 and 2016. And what was interesting to see is that over time, and you can see this is in the orange here, so you can see in 2006, about 25% of women got pregnant while they were on disease-modifying therapy with for MS. But in 2016, that number is over 60%. So overall, you know, about 47% of pregnancies are now often conceived while the woman is on disease-modifying treatment. And it's quite clear that both medical staff and doctors are becoming more comfortable with the data that's out there on these medications, and that women with MS are also becoming more comfortable with the different risks associated with this. So it's quite an interesting observation. With Miss ABC, well, she was actually, you know, not keen to start a medication because she felt that she was going to get pregnant. But unfortunately, 12 months later, she'd had another little relapse, and she developed some double vision, a little bit of balance problems. and she wasn't pregnant yet. So, you know, I was quite keen to get cracking with this, even though she was really young, and, you know, it often takes longer than 12 months, but, you know, she started to seeing a fertility specialist. But one of her questions was, you know, was she struggling to get pregnant because of her MS? So does MS have an effect on fertility, for instance? And again, the information we have on this is quite reassuring. We can see that, you know, the mean number of children for women with MS is about 1.4 in this group of information. This is from a French study, and women without MS was about 1.99. So whatever, you know, a fraction of a child would be. And it didn't take any longer for the women with MS to conceive than it did for the women without MS. So it was really similar. And that sort of really would point us to the fact that there's no evidence that there's any fertility problems for women with MS. However, we do know that as the disease marches on, sometimes problems can develop, and that could potentially impact on someone's, you know, chances to conceive. And that's often things like, you know, sexual dysfunction or endocrine disturbances, and, you know, things like that that might be happening. That's an after effect potentially of MS rather than the disease itself. Well, I guess the disease process or the immune processes themselves. So this was again confirmed in a recent study, which again showed that, you know, most women with MS in general would have about 1.38 to about 2 pregnancies. And as a woman would develop more neurological dysfunction, that the pregnancy rate might actually drop a little bit. So I don't think that, you know, it looks like women and even men with MS will have fewer children or pregnancies than people without MS, but this is a very small difference. And it's good to think about other reasons why someone might not be getting pregnant, because everybody is different, and it's really important to have a careful discussion around this. So I'll touch really quickly on sexual dysfunction in people living with MS. So this is actually really common and something that's quite often overlooked. So up to 90% of men can be affected, and in women up to 80%, which is, you know, nearly double as to that of the general population. So it is pretty common for most women, but a bit more in people with MS. Oops, sorry. And it's interesting in that most people with MS would never mention this to their neurologist. And what's even more remarkable is most healthcare workers would never actually ask about this either. What is worrying is that for a lot of people with MS, they do develop, if they have sexual problems, then they often have marital problems as well, which again is not uncommon in the general population. It often does go hand in hand. But it is something to think about, because those relationships around someone with MS is really, really important. So we also know from studies that sexual dysfunction in general have a much higher impact on someone's mental health and their mental quality of life than a lot of aspects around physical disability. So something that's really important to think about. When we talk about this, we can think about primary sexual dysfunction, which is really to do with the nervous system itself, where, you know, there's something happening that impairs your sexual response or feelings. Secondary problems, which is sort of MS-related problems that comes down the track that can affect the sexual response. And then tertiary problems, which is really all these, you know, headspace things, you know, where, you know, which is about your psychosocial perception of this, cultural issues, and how you feel about these things. So we know that there's in the primary sexual dysfunction, I guess the good news is that there's no specific sex center in the brain, which means that because lesions in the MS can be anywhere, your brain generally will just work around this. But we know that, you know, things like sensation, drive, cognition, and attention, and so forth, you know, all of these things could potentially be affected in some way. But there's lots of pathways that are spared, and there's not sort of a direct lesion to function correlation at all. We think about this in terms of things like vaginal dryness, and yeah, you know, there's generally lots of treatments for that. Muscle tone, and this can be addressed with Kegel exercises. Abnormal sensation, which could happen often from spinal cord injuries and lesions, and that can be suppressed as well. And loss of clitoral sensation could also be addressed with estrogen cream. And not a lot of evidence for drugs used in men to help in women, but I know some urologists do use Viagra, for instance. In terms of other problems, bladder and bowel problems, levels of pain, problems related to medication. So, this is sometimes something that can be fixed where certain medications can have an effect on libido or make it harder to orgasm. So that's a good point to think about talking about to doctor, to fatigue, spasticity, muscle weakness, and then also cognitive problems where it's hard to concentrate or shift attention, and other abnormal sensations could play a role. So sometimes speaking to a rehab physician would be very helpful here. Then we think about tertiary dysfunction, which is really all these above that belt issues, which is the hardest one to fix. But having a heart problem doesn't mean it's not fixable. So this is things around depression and anxiety, performance anxiety, and just sort of your lowered self-esteem potentially, or just an altered sensation of how you perceive your body after being told that you have a disease like MS. So just a sense of loss of control and a change in relationships and a change in roles in a relationship, and also of course these media images we get bombarded about all the time about how you should look and things like that. So I think it's very helpful to talk about sexual problems, and sometimes talking about something doesn't mean that there has to be a band-aid that can be slapped onto it that'll make it better, but just talking about it might actually improve things, and it could help just having a sounding board to talk about these things that's not your partner or not a close family member, and it takes practice to do this to talk about it openly and without embarrassment. But it is definitely like with anything else, the more you do it, the easier it'll become. And there's also lots of services available online on MS Australia's website, lots of places where you could have a look and get some help specifically. So with Miss ABC, she's now pregnant. But then what happens when she's 32 weeks pregnant is that unfortunately she has a relapse. So she develops again some slurred speech, double vision, some balance problems. And luckily at that stage of pregnancy, we could safely treat her with steroids, and she actually got better, and the baby did really well and was born at 38 weeks, screaming and kicking and really well. And after the baby's birth, I think we were all very stressed by this relapse that she's had, and she started on natalizumab 10 days after the baby was delivered and breastfed with that. And she continued to recover, but it took a few months, as you can imagine, having a new baby and having some new neurological symptoms was hard to deal with. But she tolerated the medication well and didn't have any more relapses, and her little boy was really healthy and well. So she continued on Tysabri for 20 months, but she was JC virus positive, and as we know, that can increase your risk of getting a brain infection called from this JC virus called PML. So she was switched to ocrelizumab, and she was planning a second pregnancy. And after stopping the ocrelizumab, 9 months after stopping ocrelizumab, she did get pregnant again, and with no problems at all with the second pregnancy. So I think, things to think about is if you're in that space where you're starting to look around for pregnancy, or you're thinking about it, even if it's a few years away, it's good to have a forward-looking plan so that you can think about what treatment am I on? Is this going to be appropriate, or should I be changing now if it's not? It's really important to balance the risk to the unborn baby, but also the mum. So which can be impacted by the reappearance of disease activity, whether it's in pregnancy or just after, which is not a great experience to have. And then after delivery, what do we do? Do we start medication straight away and deciding on breastfeeding? All these things should be discussed up front. So I'm going to move on now away from all these pregnancy things and talk about some other problems. So, and this is really health problems that can affect anybody with MS. So, and I think we don't always think about this enough. And I think, anyone can get high blood pressure, osteoporosis as you get older, and all sorts of problems. And what is also striking is that women who have a higher level of disability is often less likely to be up to date with their general health maintenance screening. I mean, I guess that's not surprising because, you would often have so much to deal with, but often things like, oh, that should be cervical screening test. That's not up to date at all. And it's also interesting that a lot of women and people with MS that I know, don't have a regular GP, or they don't actually go to their GPs, which is not a great thing to do, because we all need to see our GPs for all these things. So the reason that this is worrying is that we know that women overall, can receive poorer care around these problems. And it's quite distressing when you read studies like this that was published in the Journal of American and the College of Cardiology in America, which really sort of showed that women receive poorer heart attack treatment, for instance, regardless of whether the rates of diagnosis were the same. And so I think this is one of those gender issues, I think, that can affect all women, and makes me even more worry about women with MS and having all of these other comorbidities looked after. Something that I think is dear to my heart and that I would just like to mention to you is about cervical screening tests. So those PAP tests that are now called cervical screening tests, or CSTs. And the reason for this is, from a study that we've been doing for quite a long time, and I think, what we're looking at is particularly women in Victoria, and we've looked at, with their permission, we've been able to link their MS-related data, all the information about their MS and what treatment there are, to the Victorian Cervical Screening Registry, which is where all women in Victoria, all our pap smears and cervical screening tests, all goes to this registry. So with permission, we were able to find these records for these women with MS, and we could actually look at 221 of women with these, of which 151 of them had at least one pap smear or cervical screening test after they started, after they were diagnosed with MS. Without any abnormalities previously. And what we found really was that, a lot of women in this group was on bedaferon and Rebirth and Plegridy and Papaxone, and the older cell drugs. About 72% had used one of the higher efficacy drugs, so Gilenya, Tecfidera, Tysabri, and so forth. And a lot of women had used both, because often over the course of MS, you change treatments. And what we found is that even though it was still rare to have an abnormal screening test, and even rarer to have a very abnormal one, so only 2 really high-grade lesions, it looked like if you were on these higher efficacy drugs, so drugs that have more potent effect on your immune system, the risk of having an abnormal pap smear does increase by almost 4 times. So it's really important that we keep up to date with these tests. And in particular, with the new guidelines, we would like women with cervical screening tests to have them every 3 years, not every 5 years. So this should be covered in Medicare, and your GP should be able to get this for you, or your gynecologist. And if you do have an abnormal cervical screening test, it's really important that that's followed up by a gynecologist. I guess I just like to emphasize again that we should all be vigilant about our health. And that means that we should go to see our GPs every year to get things like blood pressure and cholesterol check, especially if you're over 40 years old. And then there's all these guidelines that start kicking in, mostly from when you're 50. And it's really important that women with MS, especially if they're on treatments that can affect your immune system, that you actually comply with this. You don't need to do anything more frequently, just the regular stuff, but you do have to do them. And it's really good to keep up to date with these. And it's important to remember that, MS is not going to kill you, but other diseases could. So it's important to keep up to date with this. Just quickly, because I know I started late, but I wanted to talk about menopause, so the whole other side of the life of women in terms of their reproductive life. So basically, the mean age of menopause in women with MS is about 51.5 years. And as for any other women who go through menopause, it's a time of transition, professionally, personally, and it can be a whole new thing to adapt to. The thing that could be tricky for women with MS is that their menopausal symptoms could overlap with their MS symptoms, so it can be hard to differentiate. So, things like, feeling more tired, feeling more depressed, or getting funny sensations, all those sorts of things that can happen in menopause could also be from MS-y type stuff. Uthoff's phenomenon, so this is where, people get very temperature sensitive. So obviously that could be set off by hot flushes as well. And unfortunately, there's not much really to tell us about hormone replacement therapy itself in MS, and does it affect the disease cause of MS at all. The thing that is becoming clear, and there's increasing, a level of attention to this in the research world, and I'm not going to go through these complicated graphs, but what we can see is that as women get older, same as for any person with MS, the relapse rates will definitely decrease. But it could be that menopause itself could be a bit of a tipping point, and could actually, trigger some transition from a relapsing remitting type disease to a more progressive phase of the disease potentially. Not for everyone, of course. I hate this word ovarian aging. I hate to think about ovaries aging, but anyway, it is the way of the world. So we know that, getting older and losing some of that ovarian function could actually be affecting brain volume as well. And it could be that might be, one of the things that protects us for most of our lives. When we lose that sort of function and hormonal drive, it could sort of transition the MS a little bit. But there's still a lot that we don't know about this whole issue. We don't know if there's any, drugs that are better for MS, for women with MS or men with MS, or which one's more effective generally. Is it that important? I think, in general, we try and individualize things as best as we can, knowing that there's no way to do it perfectly at the moment. And lastly, just finishing up, I wanted to talk about something I think that is very distressing, which is, violence against women with disabilities. I think in general, 1 in 4 women will experience emotional abuse from a partner throughout their lifetime. 1 in 5 women have experienced sexual violence after the age of 15, and 85% of women in general have been sexually harassed. There's also many studies that have shown that women with disabilities are abused more often than non-disabled women, and often for a longer time. And it's often because, people, the people who abuse these women are often people they rely on, like family and caregivers. And they may stay with a partner longer because of the fear of losing financial support or custody of their children and so forth. And also, financially, it can be much trickier if you already quite disabled from your disease, because employment opportunities could be harder to come by, unfortunately, and they're less available for disabled women than they are for disabled men, which is again one of those gender inequities in society that is just not fair and really stacks the odds against women quite a bit. So we don't know exactly if women with MS suffer from more domestic violence or domestic abuse. In one study that was done, 2004, so quite a long time ago, of 220 women with MS, 116 of these women actually completed this questionnaire, and 11% reported physical abuse, 28%, so about a third almost, reported psychological abuse and verbal abuse, 9% reported sexual abuse, 16% only would sought help from victim services agency, and 96% of these women who did suffer abuse cited fear as the main reason for not seeking help. So I always think that, again, having a relationship with a healthcare worker and someone that you trust might actually be a way for you to bring this up and find a way to find some help. So if this affects you in any way, it would be great if there's any way that we can help. So there's lots of resources for this, and I guess it's also important for healthcare workers to think about how to approach the situation. But there's lots of websites like southsafe.com.au, the lookout.org.au, Safe Steps, which you can actually look at resources on how to report this if this is happening to you, or how to seek advice. So I'm going to finish there, and I guess hopefully we can see that women with MS would have very specific needs that starts that's often into our reproductive cycle, but affects us throughout our lives, throughout the lifespan. And I want you to know that you can do and achieve everything you want to do and you've set out to do in your life. And it, and that it might need more planning though. And I think here is where it's important to speak out about problems, about planning, and and even those problems that are sometimes really hard to fix, talking about them might actually just help a bit. And then if you fail to get your message across, or you fail to get your an answer to your question, try again and try again, because it's important to be heard and to try and get the answers to your questions wherever you can. So there's a couple of resources here, which is really more around sexual dysfunction. So I'm sorry again for all the technical glitches. So yeah, happy to take. I don't know if you have any questions or what's on the program after this talk, but yes, I'll stop now.
Thank you, Anneke. That's been wonderful. I'll show my screen, and I'll just give people a little chance to type in their questions. And I'll just take a couple of minutes to go through a couple of other slides. But thank you so much for the way you've presented the things that you have learnt through your research in very practical application terms for us. So I really appreciate that. A question that someone might come to you with is often the basis of the research that goes on, so that you can give answers for that question. I think that's just fabulous and incredibly encouraging. I hope people have had their pen and paper out and have been writing down things, notes. This is what I'm going to do. I'm going to make sure I've got my cervical screening up to date. I'm going to make sure I have that conversation about pregnancy, whatever it might be. Please make sure that you use the information that Anneke's presented today to go off and do some action from it. So thank you so much. Just again, just a couple of little questions to give that buffer for typing in your questions, which you find your control panel on the right hand side. Click the little orange box with the white arrow that opens up your control panel, then open up the question heading into a dialog box where you can type in your questions. MS Connect is always there for you. So as Anneke said, if there's anything that you want to follow up, that can be a source of information for you as well. And I thought it was also worth mentioning peer support. Peer support can be a fabulous way of talking to someone else also living with MS who has had that experience that you are wondering about. So this is the team, Kat, Kim and Ange, and they can match you with someone to talk to on the phone about particular issues, particular life stage questions, particular experiences, or you might want to connect into a group as well. Just a couple of resources that are worthwhile you guys knowing about. They're in your handout packs. And let's have a look at some of the questions. I know there was one question posted around HRT therapy and Tecfidera, Anneke. Anything that you're aware of that is a complication there?
No, nothing really. I think I guess the Tecfidera, Tecfidera can sometimes cause these hot flushes, and for some people, and that's sort of almost like, for some people it's quite dramatic, where they actually almost get like a redness on their skin, and it can become really full on, and they can feel really hot. But it's not really a hormonal flush. It's much more of a blood vessel type dilatation that's happening. So the way to address that is often by taking some aspirin before you take the dose, and it does tend to settle over time. There's no Tecfidera. It's pretty good in that it doesn't really interact with other drugs. So in terms of if the question is more around someone going through menopause, being on Tecfidera and wanting to start on hormone replacement therapy, there would not be a specific reason not to do that from a Tecfidera point of view. But obviously, there's other things to think about when you start on hormone replacement therapy that people need to get advice on.
Thank you. Another question around the menstrual cycle. Is it common for the menstrual cycle to go through changes because of MS? Is there anything in that with the link between hormones and MS?
Look, no, there isn't really, and I've looked at this question quite a lot over the years, because I often have people coming to me saying, "Well, my periods now become, quite irregular, or it's changed in some way." And looking through, the studies that's been done on all the different drugs, it's not really. It's often sort of really fine prints in the subtext notes somewhere. They might say something about period irregularities, but it's not really what we would consider a common reason at all. MS itself shouldn't do anything to your cycle, and the drugs, it would be very, very unusual for them to do anything. But again, it's always worth asking the question, because there might be something specific to someone's situation. I find that just, I guess in general, sometimes as we get older and things change, periods just do change a bit. But it's always good to have a think about why it could be, and thinking about if there's a drug that could be doing it is an important question.
Great. If you're on higher DMTs, should you be getting pap smears more often?
Well, in fact, the data that I showed is still, it's still a bit early to make any, very firm conclusions. But basically, the recommendation is that a woman with MS on any treatment should have a cervical screening test every 3 years, not every 5 years. So it does, to me, appear from that information that I showed you from that study that women on the higher efficacy drugs might be at a higher risk, which would make sense, because it all relates to HPV virus infection and the virus persisting. And what we could see also is that our women with MS are often not vaccinated against that virus, just generally because I think of the age cutoffs of when people get MS and when the vaccine was rolled out, really. But yeah, I think it's a good idea to we really should be having it every 3 years.
Thank you. And is disease-modifying therapy more likely to lead to abnormalities with cervical screening?
Well, it looks like over time, if you're on a higher efficacy drug, that it might do that. But I think that we have to remember that these episodes of high-grade cervical cancer and cervical abnormalities that require a biopsy and things like that, they're still really, really rare events. But it does look like it's possible that it could be contributing to that. We're still looking at some new data that we've collected on this, so hopefully we'll be able to answer that question a bit clearer, probably in the next 6 months, really.
Great. And do we need to ask our GPs to send pap test results or breast screen results to our neurologists?
Oh, look, I think, I quite like having those results. But I think in general, most women are really good to know if their results were normal or not normal. So as long as you know the results and you can tell someone what they were, you probably don't need the big details of those reports. But if you've had a biopsy of any sort, where someone felt, a test was abnormal enough that you should have a biopsy, it is really useful to copy those, get those results copied to your neurologist, because sometimes, specialists in other areas may not be aware of all the immune changes that we would see with certain drugs, and it might affect what treatment you go on or what you stay on, depending on what they find.
And a question about the potential benefit of the pill and MS symptoms. Is there anything in that?
Look, not anything that I've seen in the literature that's been, terribly convincing. I think, there's not really a specific benefit of the pill in delaying relapses or delaying disease progression. So yeah, no.
And the questions are great, guys. There are some great questions coming in. Any more risk for perimenopausal depression with MS?
Well, I think this is one of those unanswered questions. I think, people with MS generally are at an increased risk of depression. And we know that, around menopause, women do get more depression as well. So you would think that, you can't really just add things together and say, that 1 + 2 = 4. But it does seem that it could be more pronounced in women with MS and like a lot of other, symptoms and medical problems that people get when they have MS, they could experience it a lot worse. So it certainly is possible, but there's not really a study that I can point to tell you, exactly what the risk would be.
And a couple of questions around is using HRT when people are living with MS as well. Any issues or concerns with that?
No, I think there's no real issues with that at all. There's a couple of studies that's running in the US at the moment using, the newer versions of hormone replacement therapy to see if it actually could help as treatments to prevent and slow down progression. But these are sort of drugs that are much more selective in which part of the hormone, the estrogen receptor, they affect, for instance, because there's always been concern, obviously, with hormone replacement therapy that it could increase certain types of cancer. So these newer versions of hormone replacement therapy is certainly being trialed at the moment in the MS setting, and I think we probably will start seeing some really interesting results around this next year.
Combining a couple of questions, so I hope I do these justice. Relapse rate, moving to secondary progressive, and menopause. Is there a connection in any of that, or is it an aging?
Yeah, look, I think it's hard to sort of. I think a lot of this is aging in general, and as the MS disease course, runs through decades of activity, generally relapses slow down. So people have, whereas we see these florid relapses in children with MS, for instance, as people get older and they've had MS for decades, they tend to have less and less relapses. And that's generally a phenomenon of aging. But what's interesting is that, when women go through menopause, even independent of, an age-specific thing, it does seem to, in very small studies up to now, seems to also, trigger a little bit of a step in disability changes. That is interesting to think about, because I think that is something that we could potentially prevent if we have more awareness of it and we understand exactly what happens around menopause with MS. And, so I think that might be definitely an area where we might see some treatment targets coming forward in the next few years.
That's fabulous. Is cervical screening required after a hysterectomy? Great question.
Well, usually not, but it's good to check what type of hysterectomy you had. Usually, in most people, when most women who had a hysterectomy, they would remove the cervix, which would be the sensible thing to do. But there's some women who had it, maybe decades ago, where there used to be this procedure where they, for some reason, left the cervix. So it's probably just good to make sure that that has been removed.
A question that relates to COVID. So we'll pose it and see if you have developed an opinion as yet. Sorry, I'm scrolling back up to it. Are you getting any sense about what the potential COVID vaccine might be like and whether it's going to have an impact for people with MS? Or are we far too early yet?
Yeah, look, I think, that is something that I think is going to be an interesting space to look at. And some of the vaccines that are in development are what we would call, live vaccines. So these are vaccines that actually have, some of the actual virus particle, the virus itself is part of the vaccine. And that's the same type of vaccine that we see for chicken pox, for instance, or the measles vaccine. And those vaccines are not something that we would want people with MS to have if they're on disease-modifying treatment. So there is a good chance, that the vaccines that are in development at the moment will not be safe for people with MS to have. And this is where, we will have to think about what do we do, depending on how the pandemic goes, whether we, either rely on herd immunity in the community to protect our, people with MS, or do we delay treatments so that we can vaccinate someone, or we give people a longer space between treatments so we can give them a vaccine. But all of those things have risks associated with them because they, can of course interrupt the MS treatment and cause relapse activity and things like that. So it's going to be something that's going to be quite complicated to deal with. I think we'll have to see what happens.
And we will absolutely make sure to keep everyone up to date with that, whether it's through publication or the website or through sessions like this. We will make sure everyone is up to date. Anneke, thank you so much for your time. I'm going to finish off with a comment that's been made that I think you'll appreciate as well, that says you deserve the Australian of the Year award, because you are what every doctor is meant to be and more. So we're very grateful for your time.
That's so nice. Thank you. You guys are lovely, and it was good to chat to everyone.
Absolutely. Thank you so much. Look, as I said before, I hope everyone's got something to go away with to follow up, because it's so important that we are on the front foot with our broader health care, that as well as our multiple sclerosis care. So thank you, Anneke, for reminding us and for encouraging us. Thank you for your time, and thanks everyone for being online. We'll look forward to seeing you at another program.
Sure. Take care, everyone.
Thank you very much. Bye-bye for now.